welcome everyone to this very special episode that was recorded live at the ADA Scientific Sessions in Orlando on June 24th, 2024. This episode represents a lot of firsts. The first time any of us have recorded a podcast live in front of an audience. The first time that we have assembled all the hosts of the ADA podcasts, Diabetes Core Update, ADA's podcast for primary care, Diabetes Care on Air, the podcast of Diabetes Care, ADA's clinical research journal, and Diabetes Bio, the podcast of ADA's flagship research journal, Diabetes. This is also the first time we are jointly releasing an episode across all three podcast series, something made possible by the support of Bayer. Hopefully, you'll agree after listening to this episode that it was time well spent as you listen to us discuss highlights from the ADA's 2024 scientific sessions, what we found impactful and interesting across the bench-to-bedside spectrum of biomedical research, clinical research, and treatment advances. Enjoy! Welcome, everyone, to the 84th American Diabetes Association Scientific Sessions in Orlando, Florida, and our first ever live podcast recording in front of an audience. Now, to prove, in fact, that there is a live audience here, can I hear some loud cheering and applause? See, this is, in fact, legit. Now, I am thrilled to be joined today by all of the hosts of the podcasts offered by the ADA, and I will let each of them introduce themselves and tell us a bit about the ADA podcast that they get to play with. And also in the beginning, maybe give us some general thoughts about the ADA scientific sessions and why they love coming. My name is Dr. Alice Chang. I'm an endocrinologist from the University of Toronto and fortunate to be the chair of the Scientific Planning Committee for this year's scientific sessions and co-host of the podcast Diabetes Care on Air that you'll hear more about shortly. So to get things started, let's go to the team of Darlene Sandoval, Kirk Habegger, and Kevin Williams. So let's start with you, Dar.
I'm Darlene Sandoval at the University of Colorado, and I have been coming to the ADA Scientific Sessions since I was a graduate student, actually. That is how I ended up in this field.
And that was just like a few years ago, right?
Exactly.
I'm Kevin Williams from UT Southwestern in Dallas, Texas, and I've been coming to the ADA since I was a postdoc. I think it's a great meeting to meet the leaders in the field and then also for trainees.
And I'm Kirk Habegger. I'm joining you from University of Alabama at Birmingham. I've been coming to the ADA since I was a graduate student as well. You know, this is such a great meeting to meet your tribe. Right? These are my people, and meet friends and see old colleagues.
I'm Neil Skolnick. I'm a family doctor from Philadelphia, the Jefferson system. And Kirk, I love the way you describe that, meet your tribe. And I think that's why a lot of us come here. It's in many ways, if you think about it, we live in this age of division, of so much hate, and coming together with like-minded people who have as a singular goal to help others is amazing. It's such a great feeling. It's not all about the data. The data here is interesting. It's exciting. We're going to go over it, but it's about seeing one another. Kirk, as you said, seeing old friends that you've been coming since graduate school to see, and it's the whole feel of what we get here in addition to the data that makes this so worthwhile. Mike?
Thanks, Neil. I'm Mike Rickles from University of Pennsylvania, and I have the real privilege of co-hosting the Diabetes Care on Air podcast with Alice Chang. And just have to say, Alice, what an incredible job you've done with this year's scientific sessions. We could have a round of applause for Alice. So I too first came as a clinical fellow, and when I was trying to carve out time for, can I get out of my clinical responsibilities, attend this meeting, Don Martin at the time at Penn said, go. And that was my first ADA meeting and many since. So this has really been the Super Bowl of diabetes research meetings, and glad to be here with y'all.
That's actually a great way to start. I'm going to remember just go. I think that should be the next motto or logo when it comes to the ADA Sci sessions, just go. In the Super Bowl of diabetes research. I love that. So now all of us have the privilege to be able to co-host podcasts, or in Neil's case, host himself, the podcast. So let's hear a little bit more about the actual podcast that we're privileged to be part of. So let's first hear about Diabetes Bio.
Yeah, so I'm Darlene Sandoval, and I co-host with Kirk and Kevin the Diabetes Bio podcast. And what we do is the Diabetes Journal selects a paper of the month and a few feature articles each month for their print edition. And we interview the corresponding authors. We pick a couple of those articles, and we interview the corresponding authors and any co-authors that they'd like to invite along. And so that actually has allowed us, at least on a couple of occasions, to highlight both senior and junior investigators, which is really fun. So we're going to talk a little bit about our favorite interviews, and I am picking an interview of PhD candidate Harry Cutler and his mentor David James from the University of Sydney. They presented some really fun data on a dual tracer technique to assess insulin sensitivity in mice, but what's really special was just Harry's composure as a graduate student to handle a podcast interview. It might be just this younger generation is just a little more used to being highlighted in that way, but he just did a great job, and I really appreciated the interaction and the support that David provided for him as a mentor. So that was a fun interview. Kirk, what about you?
I think that's a great choice. But I think of the ones that stick out to me, there was an interview we did with Jeff Hodkin and Alan Addy, and they're looking at diabetic nephropathy in a unique mouse model. And the data was great, but hearing them discuss how that collaboration came about, and then you could almost hear them planning the next studies in real time. And that was a lot of fun just to be a fly on the wall for that interview.
Yeah, those are great choices. I also remember the comment of the Cutler protocol in that first interview. So that was great. I co-host the Sweet Talk segment of the podcast, and in the Sweet Talk segment, we're really focusing in on special topics or special issues associated with the journal. The journal has a Classics in Diabetes series where they're looking at articles that were previously published in the journal that have some historical significance to the study of diabetes and that they want to revisit. Quite commonly, many people start forgetting articles that were published before 5 years ago. And so revisiting those articles with sometimes the authors that actually published the article is a really interesting topic to cover. Another topic that we cover is Point Counterpoint series, where we're talking about debate articles. Sometimes the debate, we're trying to bring the authors together to see if there's any kind of common concept that they can agree upon. And sometimes they're just debating their point, and it's up to the readers and to the listeners to decide. There was one interview that we did as it relates to the award winners here at the Society. We recently interviewed Carmela Evans Molina, who is the Outstanding Scientific Achievement Award winner from last year. We just had the Achievement Award winners giving their presentations today. But Carmela Evans Molina from the University of Illinois School of Medicine had a really impressive article that she wrote for the journal, and then we highlighted that article in the podcast. I would encourage investigators at multiple career stages to pay attention to that article, to go listen to that episode. She had some really good words of wisdom of how she navigated her career and inspirational quotes for you to follow. So I've been really enjoyed those different special topics.
Yeah, she's actually known for her mentorship as well, in addition to her science. So she had some nice tips in that interview as well.
I think what strikes me about all the favorites that you've talked about is the human aspect of it, right? Obviously, you talk the science, and especially when the three of you talking, I don't frankly understand a lot of what you're talking about. But what's been most impactful to you has actually been the human part, right? Yeah. The mentorship, the stories, the inspirational quotes, etc. So now let's move on to you, Neil. You don't just do one podcast, because that would be too little for you. We need multiple people for one, but for you, you singly do two of them. So tell us about them.
Oh, gosh. Well, I really feel very fortunate. Chris Kohler, who's the publisher, and I have worked together for over a decade. And we first developed Diabetes Core Update, which I and my co-host John Russell do every month, where we go over all of the most important articles, in our opinion, I'll come back to that, that come out in diabetes. Now, we're lucky in that we're able to cover everything. So before the podcast, before we select articles, I do get the table of contents for diabetes care, but I also look at New England Journal, JAMA, BMJ, Lancet, Annals, on, and pick what I feel are the most important articles for our audience, which are both general endocrinologists as well as primary care clinicians, meaning physicians, nurse practitioners, PAs, and diabetes educators. And then we both have some interviews from outside authors. For instance, last month we talked to Mikkel Kosobrod about the HFpEF and diabetes trial and have the advantage of having that in-depth knowledge of experts. And then also John and I discuss our opinions about different articles from a primary care point of view, from people who are passionately invested in the care of people with diabetes. So that's Diabetes Core Update. Then, about 3 years ago, we thought we're doing this for clinicians, but people with diabetes need information. And just like the rest of us, they enjoy getting things from podcasts, enjoy listening to it, right? The advantage of podcasts while you're on the elliptical, the treadmill, while you're driving. So we started, I and my co-host, Sarah Wettergreen, who is a pharmacist. So we have very different voices and a very different approach to the person with diabetes facing podcast, where we go over all sorts of topics. In fact, last month, we had the privilege of talking about the challenges of being young and diagnosed with type 1, and had a young man who is 17 years old, name is Nathan, come on and join us. He had an article in Diabetes Spectrum and talk about being diagnosed at 12 years of age and the importance of all the help he got from all of us, right, in the healthcare community, his parents, school. And so we cover a different topic each month. Mike?
Sounds great. So last but certainly not least, my partner in crime, Mike, do you want to tell us a bit more about Diabetes Care on Air?
Sure. So what Alice and I do each month is each of us select one of the feature articles that's present and free online to everyone. And usually one or two of the authors of those articles we pick will get interviewed by Alice or myself. In addition to those more in-depth article author interviews, Alice and I then do a rapid exchange segment where we each get to pick 3 of our own choices beyond those author interviewed articles to give our impressions on what we thought was new and exciting and exchange those ideas together. And so I'd say we have a lot of fun and have different views and perspectives from our practices in diabetes. So hope that provides a nice balance of what's the content of each issue is for the audience. There are also special interviews. Artists for cover art on Diabetes Care, sometimes pick for interviews. Alice did a terrific interview with Michael Natter, endocrinologist, author, for one of the cover arts. We did a interview of David Nathan ahead of his career profile piece that was featured in Diabetes Care. That was a lot of fun, and I encourage everyone to look at that. And then there's special collections of articles that show up occasionally in months of Diabetes Care. So recently we did a special episode covering the collection of papers on the GRADE trial. And coming up, stay tuned, there'll be a collection of articles in September covering the DCCT EDIC cohort study. So please tune into that.
So now that we've gotten the introductions out of the way, let's dive into why we wanted to have this session. I mean, we're here at the Scientific Sessions, and as we were planning this, we thought, it wouldn't be great to talk about highlights that we got from the Sci Sessions. And the reality is each of us could talk for an hour of the things that we've learned so far. And you don't want to be sitting here or listening for 5 hours or 6 hours. So we gave each other the exceedingly difficult task of picking one session. And I'll see if they stuck to the task, but that was the task that was assigned, of one session each that we would talk about in a little bit more depth and then have a bit of a conversation about, and then time permitting, we could perhaps expand it. But one thing I want to say, so as you're listening to us, and these are people here live in the audience, those who are watching from home, and then those who are subsequently listening to this podcast, if you're thinking, oh, I missed that, I really wish I could see that, don't you worry, you absolutely can. So just a reminder that you still have access to the sessions from the Scientific Sessions meeting. So if you were registered to have attended the sessions, then you have access through to August 26th. Or for those of you who haven't signed up and are just listening on the podcast and want to sign up, you can still do so at scientificsessions.diabetes.org, and you have on-demand access until August 23rd. So therefore, don't worry. If you hear something cool, you can go still watch it. All right, so now on to content. We're going to start off with the Diabetes Bio team.
So I just want to say that we cheated, or we either cheated or we didn't pay attention to the assignment, because we're splitting one discussion, and also we interviewed this person before. So
It's okay. It still works.
That's right. So we thought we'd start with the big award, the Banting Lecture. And we just walked out of that talk. It was wonderful. This year's winner is Dr. Roy Holman. Dar, you want to tell us a little bit more about our interview and also about his work?
Yeah, so I think it's important to mention that he's not just the Banting Award winner, but he previously won the Outstanding Scientific Achievement Award and also won the Distinguished International Service in the Cause of Diabetes Award. So actually, that's kind of a good note that you can, if you see who the Outstanding Achievement Award winner is, you will likely see them in a few years on the Banting stage. So pretty cool. He is Professor Emeritus of Diabetic Medicine at University of Oxford. And we interviewed him just last week, I think. So Kevin, do you want to tell us a little bit? You led this interview. You want to tell us a little bit about what your favorite thing was about the interview?
Yeah, well, one favorite thing is that he was so gracious to offer his time within, it was about 4 days, I think, prior to him traveling over here from the UK to come to this meeting. And he said he was going to bringing his son, so there was going to be some family there for him, and it was really exciting for him. But yeah, attending the talk and also talking with him, it just is impressive career. It's so many groundbreaking research opportunities that he was involved with, of defining declining beta cell function as a contributor in type 2 diabetes. And he was involved with the development of many automated diabetes management tools. And it was really impressive to watch all of those technologies come up during the presentation, from coding on computers to guidelines that were being distributed and across for the treatment of diabetes. He's really an impressive individual, and it's really nice to see him get that award.
It was a really cool example of using science to really impact diabetes care, right?
Yeah. And the automated insulin pen and the automated Lancet. I mean, there are so many things he contributed to. So
As you're saying that, the thing that I notice is how important it is to have people who draw from other fields. So obviously, he's not just a scientist. He's someone who pulled in computer science and engineering. And I think that's in many ways can be an aspirational goal for all of us. What do we learn from others in other fields?
The other thing that really struck me about his lecture were the stories. Like, to be able to see, and he had pictures too, but to be able to see hear the story of how UK-PDS came to be, right? I mean, UK-PDS came to be because he presented at the IDF data around the importance of basal insulin use to achieve normal glycemia in type 2 diabetes, and apparently it was poorly received. So this critical study that has completely transformed how we manage diabetes came about because of what some, at the moment, he probably felt like a failure, probably felt like how people didn't receive it well. He could have stopped, but instead it was, no, let's prove this point. And then him and Professor Taylor, they got together and actually created this, which I think is fun. And I think I tweeted something to the effect of, you showed them, like that was kind of the sense, which was so lovely.
But Alice, isn't that a great example of how we're all involved when we are critical consumers of information? We say, I don't buy that. And it forces us all to be better and prove it.
So we did want to highlight another session, and that's every year the Diabetes Journal hosts and plans a scientific symposium. This year, the name was It's All in Your Head, CNS Control of Systemic Metabolism. That session was chaired by Jennifer Estall from the University of Montreal. And we thought we'd just spend just a few seconds highlighting each of the talks that were in that symposium.
Yeah, so the first talk was by, and I am going to apologize in advance for my inability to pronounce this, but Zaman Mirzadeh from the Baroneurological Institute, who provided a really nice overview of neural control of blood glucose, including some old school data about the portal signal, which was actually collected by one of my PhD co-mentors when he was in Alan Charrington's lab as a postdoc. So that was kind of cool to see.
Yeah, and then there was another talk by Dr. Laura, and I'm going to have to apologize too, Ruprecht from Duke University. Her talk was about what the brain says to the gut and what the gut says back. She has developed some really, really cool techniques to use flexible optogenetics to interrogate signaling in the gut and the neuropod cells and vagal control of systemic glucose and even lipid homeostasis.
Yeah, she's an up-and-coming junior investigator, so keep your eyes out for her.
And then Christy Townsend from Ohio State University studies the neural communication to and from adipose tissue or fat cells. And she had work looking at aging as well as obesity and increased adiposity and how that might affect the innervation of the adipose tissue. With increased adiposity, there was a decrease in the innervation of the fat cells, and she had implications for how that might relate to metabolic disease. So that was pretty fascinating.
And last but not least, we need to highlight our our own co-host, Kevin Williams, who also presented his work. You want to give us your elevator pitch of your talk?
Yes, a little bit shameless self-promotion there. The work that I was doing was related to exercise and how that might impact the central nervous system, specific cells in the brain that are involved in the regulation of food intake, body weight regulation, and blood glucose control. We were able to identify a population of cells that were activated in response to exercise, and then that activation appeared to be required for sustained improvements in insulin sensitivity that can be occurring after exercise. And so we find it fascinating that there could be a link between increasing physical activity to the central nervous system that could actually be affecting peripheral metabolism.
And before we move on to Neil, 'cause there are three of you, so technically you're allowed 3 sessions. So we've only heard 2. So anything else that you wanted to highlight for our audience?
Kevin, do you want
The
to tell us
Pathway
about
Awards,
the Pathway Awards?
how many people in the audience are familiar with the ADA Pathway to Stop Diabetes Award Initiative? So I see just a few hands. So this Pathway Initiative is actually a very important initiative by the society, and it's really geared towards trying to advance the careers of junior scientists in the study of diabetes. This award mechanism, typically it's around a 7-year funding mechanism, and it can help greatly to transition a junior scientist into an independent career.
Yeah, so Friday there was actually a session, Friday morning, I believe, and I feel like this is a new thing that they've done. It used to be like maybe these Pathway Award winners met on Thursday, and we didn't really get to see them present, but they've opened that up. And so Friday, Kathleen Page, who is at USC and was a 2014 Pathway Award winner, presented on early encounters, diabetes exposure before birth shapes brain pathways and metabolic risk. And then Paul Cohen also presented. He's from the Rockefeller University, and he was a 2017 award winner. And his talk title was, "Is There Such a Thing as Good Fat?" And then last but not least, Deborah Sobreya from Northwestern. She's a brand new award winner from this year. She's from UCLA, and the title of her talk was "Decoding the Puzzle, Unveiling Type 2 Diabetes Genetics Via Multiple Omic Insights." And then, Kevin, the journal has done a bit of work to highlight this Pathway Award
in trying to find out
winners. Do you
more
wanna talk
information
about
about
that?
the Pathway Awards, we've actually interviewed the co-chairs of the committee of the ADA Pathway Awards, and that's Lou Tomlinson from the University of Chicago. It's also Chris Newgard from Duke University. They came on the program, and they were able to give a historical context of why they developed this program and what it means for junior investigators. And then also they gave some tidbits of knowledge as to what they're actually looking for in their applicants. So I would greatly encourage you guys to go check out that episode. At that same episode, we actually interviewed a previous ADA Pathways Award winner. It was Celine Riera from Cedars-Sinai in LA. And she came on the program to discuss historical context of what she has done in her career, but then also what the Pathway Award has actually meant for her and being able to establish a lab independently in California. So it's really a great program. And please check out the program, check out the podcast in order to find out more information.
That's great.
So thank you. Thank you to the Diabetes Bio team for sharing your highlights for this year. Now on to you, Neil. You just get one. Which one do you want to highlight?
This was hard to decide. It's like a kid in a candy store. Oh, we shouldn't say that. But it was hard to decide. But I'll tell you, the perspective I come at this from, for our audience, which remember are people with diabetes and primarily general endocrinologists and primary care clinicians, is what is going to affect a lot of people. And so the SURMOUNT OSA trial of tirzepatide for obstructive sleep apnea was what, Alice, I definitely felt for me stood out. And the reason why is more than half of our patients with diabetes and more than half of our patients with obesity have obstructive sleep apnea. Now, that's not to say that they are diagnosed with it, right? Because we know we can do better in terms of making that diagnosis. We know it's important. It has serious consequences, increased cardiovascular mortality, and decreased quality of life. But the treatments are sometimes challenging, and patients don't always love CPAP. So this trial said, let's look at, and it actually was two trials. One was in people without CPAP. One was in people who were on CPAP, but the assessment was done with people off of CPAP for a week. They enrolled. This was a phase 3 randomized double-blind trial of over 450 people. As I said, trial 1 not on CPAP, trial 2 on CPAP, who had moderate to severe OSA. For those who like numbers, the apnea-hypopnea index was approximately 50. What that means is that people on the average had either apneic or hypopneic episodes, right? That partial or complete stop and a breathing on the average 50 times an hour. So a lot of sleep disruption, treated with, randomized to tirzepatide with a target dose of 10 or 15 milligrams versus placebo. What they found, the primary endpoint was a decrease in the number of, in the AHI, the apnea-hypopnea index, which is basically the number of apneic and hypopneic episodes per hour. They saw a decrease of approximately 25. I'm not going to separate out the two groups right now for our purposes, for the sake of time. Big difference. So decrease of about half, a little more in the apnea-hypopnea index. But what was even more important to me as a practicing physician was a predefined secondary endpoint, which was the percent of people who had an apnea-hypopnea index of less than 5 and or a apnea-hypopnea index of 5 to 14 with an Epworth sleep scale of less than 10, meaning not sleepy during the day, because that's the group for whom CPAP is generally felt to be probably not needed. So they went from moderate to severe disease, really requiring an intervention, over the course of the year on treatment, and the p-value compared to placebo was less than 0.002, so that on treatment, about half of the people, it was 42% in one group, around 50 in the other, about half the people essentially got to a point where they didn't need an intervention. So what are the implications of that? I think potentially the implications are that instead of having to send every patient that we in primary care diagnose with sleep apnea to a sleep lab, because the truth here is there would not be enough sleep specialists in the world to take care of all those people if we start diagnosing them like we might be able to, that we can, in our own offices, make the diagnosis by ordering a sleep test. It can be a home sleep test. They can be treated with medications that we are used to using. Patients can, many of them can have significant improvement or resolution of their sleep apnea. We need to make sure we do that follow-up sleep test to see who didn't respond. And in addition, have all of the benefits with regard to weight and cardiometabolic outcomes that we're all familiar with. So I think that has a lot of very real implications. I'm interested in others' thoughts. Alice or Kirk?
Yeah, Neil, I think that's a really, really cool study. And I immediately want to know, is this all because of reduction in weight loss? Or are there some, is there some magic juju here, maybe in the CNS, that GIP GLP agonism is targeting.
Yeah, I'm sure there'll be a lot of discussion around that. And I'd say we know the endpoints. I suspect a lot of it is due to the weight loss because we see resolution of sleep apnea with weight loss, whether it's in bariatric surgery, for instance. Are there other pleiotropic effects, as has been postulated for the GLP-1s in other areas? Maybe.
And I think it's important to remember that those who are living with obstructive sleep apnea, the impact that it has on their quality of life is quite tremendous. Wearing CPAP is not fun. Most of the people that I serve, the patients I see, they're not wearing it. And then you see the impact on their metabolic parameters, but also on their daily function, right? Just thinking straight, being able to do what they need to do. Like there's no way one could sit through a conference if they hadn't been wearing their CPAP, for example, right? So just being able to help from a symptom score perspective is fantastic. And it's nice to put numbers around it, but I'm sure everybody just felt better and their diabetes control and everything else would also improve. And you know, whether or not it is you called it juju?
Yeah.
Whether or not it's the juju or if it's the weight loss, it'll be interesting to see, but it won't change what we'll do in the office, but it's a necessary question academically to try to answer.
Yeah, it's interfering with a vicious cycle, right? You can't sleep, your metabolism gets worse, right? And so if you can disrupt that cycle, it's beneficial for the patient all the way around.
And after this conference, I'm going to sleep for about 5 days to catch up. Mike, either thoughts about SURMOUNT or if you wanted to also share your specific.
Yeah, so I'll segue from to pick up on Neil's pick, which really provides another option for patients. And I think having more options for difficult and challenging disorders like obesity, like sleep apnea, and like diabetes. And so for my pick, I sort of spend the 4 days here at ADA in sessions that relate to my research, in sessions of common clinical problems that I want to stay up to date with. But then also I like to find something that's out of the box and learn something that I wouldn't otherwise typically come across in my practice or research. And so for me, that came with the session describing the results of the INHALE-3 randomized clinical trial. This session was chaired by Roy Beck from the Jaeb Center of Health Research that coordinated this study. And this is a study of Technosphere insulin or Afrezza, which has been around for a while, but hasn't really penetrated the market in clinical practice. And so this group, starting with a talk by Halis Akturk from the Barbara Davis Center, who really reviewed the rationale for inhaled Technosphere insulin. And that is really the rapid onset and rapid offset of this insulin. It does take about 2 times the dosing for bioequivalence relative to rapid-acting analogs that we're all used to prescribing. And it often requires redosing about an hour or so after a meal to deal with any residual postprandial increase in glucose. And so they did this study in individuals with type 1 diabetes. Yogesh Kudba from the Mayo Clinic went over the design. So that it was a randomized 1-to-1 for 17 weeks of intervention, non-inferiority design. And they combined the Technosphere insulin with Degludec insulin as a basal insulin. And then usual care was the comparator. And the Technosphere insulin was dosed pre-meal, and then if needed, and that if needed was if your glucose was above 140 an hour to an hour and a half after a meal, you could take another dose to correct that. They randomized 123 individuals, and interestingly, usual care ended up with about half automated insulin delivery users and about half multi-dose injection users. Ruth Weinstock from SUNY Upstate Medical University went over the in-clinic meal challenges that were performed and showed that relative to dosing a rapid-acting analog, the Technosphere insulin led to significantly lower glucose excursion during that meal test. And that effect got improved over the 17 weeks as doses were optimized. Carol Levy from the Icahn School of Medicine at Mount Sinai went over the primary outcome data, which included that the hemoglobin A1C stayed at about 7.5% in both groups. So the study met the non-inferiority endpoint. And interestingly, in the Tectosphere insulin group, some actually had a reduction in A1C, and then some had an increase in A1C. And so we can get into that a little bit more, but it seemed to be a good option for some, and maybe not for everyone. There was about 25% reported some mild cough at inhalation that could be dealt with a sip of water, but there was no change in pulmonary function tests. Grazi Aleppo from Northwestern University went into the subgroup, so those on automated insulin delivery did a little better with glucose control overnight, as we might expect. And those on Tectosphere insulin really needed to make sure if they needed a postprandial correction at bedtime, that they did that, because that dinner dose would be long gone if they weren't normal going to bed. Earl Hirsch from University of Washington gave his critique, and Earl's pearls on the use of Tectosphere insulin. And so what Earl explained is that the optimization really showed that it was more of a 3-to-1 ratio of what you needed to bolus with Tectosphere insulin relative to rapid-acting insulin analogs, and that the overall total daily insulin dose was about 30% basal to 70% bolus. So that's a little different. And then 60% of the MDI users wanted to stay on this at the end of the trial. And maybe more surprisingly, 40% of the AID users rather stay on Tectosphere insulin than go back to their pumps. So Tom Blevins from Texas Diabetes and Endocrinology then gave tips for implementing this in clinical practice, including how to do the education and the in-office pulmonary function monitoring that's required to watch out for safety. So I think really a very interesting option that may really benefit some of our patients, and we should all be thinking more about than we have been.
Thank you for that, Mike. It's not something that we have available in Canada, actually, and something that we sort of look at with a little bit of envy in that it's available in the United States. So it's not something that I can speak to as having any clinical experience with. It briefly came to Canada, like it literally came for one day, told us, oh, it's here, and then it became it's not here. And I don't know the ins and outs as to why, but to see or to hear these data, I think make me kind of want it and have it as an option for my patients to be able to play with. Neil, what's been your thoughts?
My thoughts are exactly that as an option, it's important to have options. And what's fascinating to me, they did this right. They didn't just compare it to multi-dose insulin. They compared it to AIDs, so that regardless of where someone is at or what they have, it was the right comparison. And I'm amazed that someone with an AID would choose it, but they did. And it speaks to how we are often surprised at what others feel. And we shouldn't assume we know that what's best for someone else. And it reminds us of the importance of options. It's nice to see that shown in a clinical trial.
That's a really great point, and that really struck me as Mike was talking about that. I too was surprised, because we always talk about AID being this magical thing, and it has been, but this magical thing that's reducing burden and obviously improving glycemic control. But there is still a burden, because you are still wearing something, and you still got to push buttons, and you still got to do other stuff. So I think it speaks to Neil. You said it great. It's offer options, right? We can never assume what a given individual is gonna want to use. So now it's my turn. Again, it was extremely difficult to pick just one session, but I'm going to go with the panel discussion on the use of GLP-1 plus or minus GIP in the perioperative setting. And the reason I want to choose that one was because it's a clinically such a hot topic. Probably all of us here have had a patient within the last year, perhaps have a surgery canceled or an MRI canceled or something canceled because of this question of, oh, that wasn't held, therefore you cannot have. So the question that the panel was trying to address is this in fact legitimate? The panel was chaired by Dr. Lee Perot, and the panelists included Dr. Girish Joshi, who's actually the lead author of the consensus guidance on this topic from the American Society of Anesthesiologists, and Dr. Jana Hashash, lead author of the Rapid Clinical Practice Update on this topic from the American Gastroenterology Association, And then we had Dr. Sue Peterson, an endocrinologist and obesity medicine expert who's been part of Obesity Canada and Diabetes Canada guidelines. So we purposely built a multidisciplinary panel because this is where the controversy came from. So if you recall, the anesthetist put out a guideline that said stop. And then the gastroenterologist came out and said, well, you don't necessarily have to stop. And then we, the endocrinologists and diabetologists, were kind of going, okay, well, now what do we do? And then the poor patients were the ones who were getting their stuff canceled. So I have to say, I walked into that panel thinking that we were just going to hear the arguments of each side and there wouldn't be a happy ending, but there totally was a happy ending. I don't know how many of you were able to attend it, and I'd certainly watch it online. But what the panel did was they got together. So they each presented, from their respective specialties, what the perspective was. But they actually got together prior to their presentation and actually came up with their own consensus recommendations. These are not official recommendations from any particular society, but the question did get asked, can you please make them official recommendations from society? So I would keep our eyes open for that. But what I loved is they were practical. They were very practical. So let me share those with you. So they talked about avoiding elective surgeries during dose escalation of a GLP-1 plus or minus GIP agonist, with the idea that during dose escalation is where you might run into the most trouble around retained gastric content. They talked about looking for high-risk features, and the high-risk features of aspiration with general anesthesia would include the presence of symptoms. So if you have a patient who is still experiencing nausea and hopefully not vomiting, but nausea or having a lot of symptoms, we should be more careful with that individual. What does more careful mean? The potential to maybe change the way the dietary advice that we give pre-procedure. Current procedure advice is usually NPO after midnight, right? So nothing to eat by mouth after midnight, but perhaps implementing a liquid diet for a couple of days prior, maybe another way to do it. And there were some beautiful images shown of even some of the liquid may still be there, but it could actually be, it's a smaller amount and could potentially be aspirated, certainly from a GI perspective. And then the use of gastric ultrasound in sort of more high-risk cases where you have to do something. The anesthetist talked about rapid sequence induction. And then I love the last one, which is include endocrinology or diabetology, because if you do stop it, their sugars might get worse. So just someone else has to deal with the sugars. So I liked that part, which I thought was important. But those I thought were very useful, practical tips and recommendations. But the other great part about being live at these sessions is the questions that come up after a panel. So Professor Michael Nock, who everybody knows, right? If anybody's going to know about what the stomach's going to do after these agents, it's Professor Nock. So he came up and gave a comment about he's not convinced that it's actually the agents, because in all the studies that he's done, of which there have been many, he's saying that the contents are gone. Like that's not the issue. He wonders how much of it is just the diabetes itself, and that perhaps this has brought something out that it sort of amplified something that was always there. And perhaps just the diabetes itself is already enough of a risk factor. And then in certain individuals, adding the incretin-based therapy is just tipping them over the edge. So he sort of challenged whether we're sort of freaking out about nothing. I'm paraphrasing. He said it much nicer than that, but that was the sense that I got. Any thoughts from the panel?
Oh, gosh. I mean, it's a real important issue. It came up for us last week. And I always think it's fascinating when there are competing guidelines and opinions. And really, it often comes down not to data or evidence. It comes down to values, right? The anesthesiologist values not having a problem during period of surgery. The gastroenterologist values being able to move ahead and get those procedures that are so important done. We value getting those procedures done and making sure they're safe and not wanting their sugars to go all out of control, which when you value too many things, you do end up a little bit confused, which is where I end up on this, because it is really hard to sort that out other than to acknowledge, depending on perspective. And therefore, I think ultimately what your institution has as a policy and what you feel is the clinical imperative for the individual patient is what you end up doing.
Yeah, and so Dr. Nauk's point about underlying diabetes or subclinical gastroparesis, which I think we may be unmasking in a number of patients, and so there are many patients who will tolerate these agents quite well and may not have issues with retained gastric contents, and then there's going to be that subset. So I really think it was helpful, the guidelines for identifying who may be at high risk by when they're up titrating dosing or when they're having ongoing symptoms, to be more cautious. I want to give a shout out because I'm really, one of the other great things about the ADA meetings is being here with your team. And so we've got the team of Penn current and former fellows here in the audience, and Jorge Yo Kamimoto, who directs our inpatient diabetes service. I really want to attend that session, was somewhere else. Jorge was there, and so he filled me in. So I got to say, one of the pearls about the liquid diet, extending the liquid diet for a day, like we do in colonoscopy, where they have less problems than with upper endoscopy, where it's just a midnight NPO period. And so that, which I think really helps mitigate the risk of extending the fasting period, where we can really get into more trouble with deciding what to do with our insulin and other anti-hyperglycemic medications, but allowing for a longer liquid diet, seems like a great mitigating solution as well.
Yeah, I agree with that completely, Mike. And I also want to point out to the audience that Mike has just patted the audience with all of his friends, is essentially what Mike has done. So thank you for coming. Very much appreciated. So time has flown by. We've only got about 11 minutes left. So I thought maybe what we could do is a very quick rapid fire of one other session. Mike is looking at me going, he wants two. If you can do it fast, you can do two, but I'm talking headline of two other sessions that you want our audience here live, as well as our listeners, as well as anyone watching at home, of other things that you thought was super cool that you really want to make sure that people get to see. Now, I see that Dar is like holding her mic tight because she wants to go. Dar, you go.
I attended a session on Friday that was CNS actions of the GLP-1 receptor analogs that are non-feeding in body weight, so beyond body weight control. And so there was a talk about alcohol use disorder, which has made a lot of headlines and I think is really interesting. There was also a talk about inflammation, which I think is also really interesting, especially since we don't think that these drugs, or at least there seems to be more of a consensus that these drugs don't cross the blood-brain barrier, but then it seems like there's also a lot of data to suggest there's an anti-inflammatory effect. So I thought that was fun.
Excellent. Thank you. Kirk, you want to go next?
Sure. It was actually very similar for me, but on the weight loss specific side, there was a great basic science symposium on weight reducing mechanisms of GLP-1 based therapies. So this session included discussions of GIP and GLP-1 co-agonism in the CNS. That was by Timo Muir. Neurocircuits regulating food intake by Carolina Skibicka. Sorry if I missed that. A great discussion of GLP-1 analogs and brain penetrance by Stefan Trapp. Kind of touching on, does it matter if the systemic analogs are brain penetrant, and do they have to necessarily mimic endogenous GLP-1 from the brain or not, right? And then a great talk by Tito Borner on the antiemetic role of GIP, which I think will be a really interesting application of this class of drugs moving forward.
Thank you, Kirk. Kevin?
Yeah, I definitely agree with the GLP-1 GIP incretin talks that have been going on and the possible locations in the brain that they're activating. But I'm just going to cheat a little bit on a session that hasn't happened yet. It's going to happen this afternoon. It's the 30-year anniversary of leptin. And that's coming up this afternoon. So be really excited to check that out. It's going to be chaired by Jeff Flyer. The panelists are going to include Martin Myers, Philip Scher, Stephanie Fulton, and Rudy Leibel. And it's hard to believe that it's been 30 years since leptin was discovered, and all of the advances in understanding body weight regulation, glucose regulation through molecular genetic models and preclinical stages. But then also, if you think about previous award winners, Outstanding Scientific Achievement Awards, Banting Awards, to Siddharth Faruqi from the UK, as well as Stephen O'Reilly, which have shown relevance of leptin physiology in humans and a translatable relevance down into rodent models that we could try and better understand what's going on in the circuitry in the brain, but also in systems analysis that's a little bit more difficult to do in human physiology. So I'd be really interested to see what's going on in that session this afternoon.
I'm just envisioning it's going to be like a leptin love fest, is what it's going to be, right?
Yeah.
Yeah. That's what
Well, I mean, with the GIP, GLP-1, they need a little bit of love.
Oh, nice, nice. Neil.
Well, how could we end this podcast without talking about AI, right? So artificial intelligence in nutrition, I found fascinating. So it turns out, consistent with the thing we talked about, we're all different. And we don't all respond the same way to the same mix of carb and protein. And that's why all of these diets that many individuals strongly believe in don't work for their friend. And there were a number of lectures on really incredible AI models, and one where it created a loop where it read the CGM as well as the food diaries of what the individual put in, and over time was able to then feed back and give specific advice about the correct mix of foods for that individual to maintain an optimal blood glucose level, not too much spikes postprandially, and lead to weight loss. So the promise here, I think, is amazing. And you can't just put this in ChatGPT yet, but that may be to come.
Thanks, Neil. Mike?
All right, so my two fast sessions to tell you about are still to come yet today. So do all stick around. And this is not to compete with Kevin, but to provide options. So options to the Leptin Love Fest. We've got starting right now in a few minutes, 1:30, the three journals, Diabetes Care, Diabetes, and Diabetologia, have developed a symposium on the heterogeneity of type 1 diabetes, and that's going to address everything from the pathogenesis to prevention and treatment. So encourage everyone to check that out at 1:30, and then at 3:30, there will be a session giving the results of the ATTEMPT trial of SGLT2 inhibitor use on glycemic and renal outcomes in children with type 1 diabetes. So really pushing the envelope on where we might find evidence for use of these agents in pediatrics. So I encourage you all to check that out.
And for me, the LENS trial, which was on the Friday, was a real game changer. And that was a study of fenofibrate. Remember fenofibrate? Old friend, fenofibrate. Fenofibrate, 145 milligrams a day versus placebo in people with diabetic retinopathy. And being able to demonstrate a reduction in progression of diabetic retinopathy as well as maculopathy. And yes, we had some data suggesting that already from Field and from Accord, but then to actually have it as a dedicated eye study was very powerful, and I think really puts it back on the map. And honestly, even though we'd think our ophthalmology colleagues would be the ones who would prescribe it, they may not be as comfortable prescribing systemic therapies, but we should be. So I think it's actually critical and game-changing, practice-changing. So I think that's one I would certainly highlight for people to check out. So the hour has flown by. And one of the amazing things about coming to conference, and you've all alluded to this, is the being amongst your people, right? Everybody here is passionate about diabetes with a slightly different perspective, brings different expertise to the table, but the same common goal. And to be able to just nerd out for an hour here with all of you nerds as well, and I mean that with love and affection, is just great fun. And that's the whole point of meetings like this. And I encourage everyone here to make sure you come back. To everyone watching at home, you might want to come in person. And for everyone listening who's never been, to certainly try to come to ADA Sci sessions. And again, just a reminder that access remains available for on-demand sessions, like all the ones we talked about that you probably couldn't get to, until August 23rd, if you register now at scientificsessions.diabetes.org. Or if you're already a registered attendee, you will have access until August 26th. So a huge thanks to my fellow co-hosts for taking part in this live podcast recording, and to our awesome audience for being with us today. And remember to check out and subscribe to the various ADA podcasts that we have. So Diabetes Bio, Diabetes Care on Air, Diabetes Core Update, and Diabetes Day by Day. And there is bound to be at least one that is going to appeal to your interests. So thank you very much, everyone.